before all this began, we had about 20 different programs where we were offering direct-to-patient telemedicine consultations, and we're doing about 20,000 visits a year. So, we had a little bit of a head start on this, but it only accounted for about 1% or less than 1% of all our outpatient visits. So it still was not really mainstream. We had training involved. It was like an online learning module, and patients would get, or sorry, providers would get credentials and privileges for it. And we were using Zoom as our technology. So we had a pathway, but we very quickly realized that our processes didn't scale. So we had to really pivot to how we were releasing these trainings and how we were working with our billing department and with IT. So our total volumes are up about 70-fold, up to about 15,000 a month. And I think for the most part it's going well. We've learned about the importance of the platform and how it integrates with your EMR. And then the other things we've done is we had a virtual clinic that was contracted out and with a national vendor. And at first it was able to accommodate that surge, but then as the COVID kind of rolled across the United States, we really saw that being utilized heavily and resulting in wait times for that. So I think everyone kind of got caught off guard by how quickly this would scale up and patients wanted to use it. We also implemented a tele-ICU product. So that's for patients who had COVID-19 or in the ICU, and basically entailed a monitor and 2 high-def cameras, and it could be wheeled to the patient's bedside so that we could talk to the patient, look at if they were intubated, we could see their vent setting and see their drips without having to gown up and potentially expose healthcare workers to that. So that's been a useful product. And then we're also scaling up our eConsult platform, which is more of a asynchronous EMR-based program. So that's kind of where we are. In terms of advice, I think probably the first thing to really focus on is your workflow. So just think how telemedicine is going to be rolled out in your clinic. And are you going to batch these patients? Are you going to kind of sprinkle them throughout your day, or what types of patients is this appropriate for? And those are things that really need to be made at the clinic level, because each clinic has its kind of unique patient population and challenges and things like that. The second thing is just the importance of training and making sure everyone is comfortable with the practice of telemedicine. Make sure they know about the etiquette. So very easy things like when I start a visit, my badge is way down here on my hip. So if you're meeting me for the first time, I want you to see my badge and know that I'm a doctor for real. And also, you kind of want to pan your room. I would not advise using a background like this. So you'd probably want to go to, at least start off with something like this and just show that I'm in a secure room, just me. And you'd want to do that with patients as well. We do require, ask that we get consent from patients explaining the pros and cons of telemedicine. You obviously can't reach out and touch them and feel their belly. A lot of times you can't listen to their lungs. So just acknowledge that limitation. And a lot of times people are curious about the IT security, so we talk about that. And then the last thing I wanted to talk about is reimbursement. So before all this, the reimbursement for telemedicine was kind of all over the map, with Medicare probably being the most difficult. So Medicare only paid for patients if they were in rural or underserved areas, and they also could not be in their home. With this epidemic, they have temporarily relaxed those standards, so it's not permanent and may change, but that was a great change. And then for Medicaid, they were not necessarily paying at parity for an in-person visit, but that did change. And then the commercial plans were probably a little bit further down the road than either Medicare or Medicaid. But For the most part, I'm telling my colleagues that you can get paid for telemedicine visits. It's almost always going to be at parity for an in-person visit. And you pretty much document the same way. You just add a GT modifier to when you're dropping your bill. So that's kind of a quick overview. Hopefully that answered a lot of the basic questions, but maybe we'll just open up for Q&A now. Lana, if you wanted to kick it off with the first, and then people can either chat or raise their hands.
Great, thank you. One of my first questions is, so we have patients on, medications that can tax their liver, and just kind of, if there's any virtual exam kind of tips that you might have that might help us kind of assess that when we're doing our regular check-ins from like a case management perspective or from a provider standpoint.
Yeah, I think there's a couple things you can do. I mean, by having video, you can look at their eyes, so you can see if they're jaundiced or not. And usually you can pick up jaundice if the bilirubin's over 2 or 3, which is pretty high, and that would make me really concerned. And then in terms of like feeling for hepatitis, you can ask the patient to kind of self-palpate in the right upper quadrant. But kind of wearing my hat as the director of the liver clinic here, I can tell you that pain in the right upper quadrant is often a late sign for any kind of hepatitis, and some people can have it and have totally normal LFTs. So my recommendation is, if you have patients who are taking some of the hepatotoxic medications that are often given for TB, figure out a way where patients can safely get their LFTs monitored. I would not rely on the physical exam to monitor for the safety of these medications.
Thank you.
Yeah.
Anyone else have questions? You can either raise your hand. Oh, there we go. Dr. Chandler.
So back in the old days when we saw patients face to face, we'd call in the telephone interpreter line to, bridge the language gap. Can you do something similar with Zoom, and can you actually see a real life interpreter as your?
Yeah, so that's a great question, Dr. Chandler. And I think it really depends on your arrangement. At UW Medicine, we contract with an interpreter service called Stratus, and we do have the ability to bring in interpreters for 36 different languages, including American Sign Language, and they're on video. It's just through the participants thing. We just can invite them. It's pretty darn easy. The other way is we still have our phone interpreters, and we just give them the Zoom link, and they can call in through phone. But the video is really nice because there's a lot of nonverbal communication that the interpreters can help out with as well.
Sounds great.
Yeah.
Did you say that was Stratus or Strata? What was
Stratus,
the name of it? Sorry.
Stratus, yeah, STRATUS.
Thank you. All right. More questions? And if you're not on video, feel free to unmute yourself and pop in.
Well, people are thinking about questions. I think a lot of people are just wondering, where do I go? I've never done telemedicine before. I don't even know where to start. And the good news is that every region in the country has something called a Telehealth Resource Center. These are federally sponsored through HRSA. In the Northwest region, it's in Utah. It's called the Northwest Telehealth Resource Center, or NRTRC. And they are great resources for technical questions like which platform should I use, to basically how do I conduct a telemedicine visit. They are required to give at least 10 hours of free technical assistance. So I would refer folks to that website. And then the other resources, the American Telemedicine Association, or ATA, they have made all their guidelines publicly available. So if you wanted to learn, like, okay, what's involved in the training? How do I introduce a patient? Kind of things. I mentioned, but you want to go more in depth, those are available as well. So those are two great resources. If you're in Washington State and you want to hear about the training here, the Washington State Telehealth Collaborative has a video that is available to the public, and people can watch it. If you wanted to get CME credit, there you can pay like $25 and get CME for it as well. So those are three great online resources that are free or very low cost.
Thank you. Questions?
Is Zoom confidential?
So Carolyn,
Oh, great question. Yeah.
Great question. So I guess the more important question is Zoom HIPAA compliant? And it depends on how you've configured Zoom and what your relationship is with Zoom. So what we've done at the University of Washington is that we have a enterprise level agreement with them because our whole university is using it. For upper campus, they're using it for teaching students and things like that. So when we purchased these licenses from Zoom, we had a legal agreement. It's called a Business Associates Agreement, or BAA. And they agreed to abide by HIPAA rules. So if there's anything on their end where they're not handling the patient identification and things like that, then they're on the hook. So I would say you need to have that kind of an agreement with whoever vendor you go with. But then more importantly is how you configure Zoom. So you know that there's all these little settings that kind of show up on the bottom of Zoom, like the record function, that little circle there. If you are doing this with patients, please turn that off, because you don't want, it'd be like you having a conference with a patient in person and having some kind of recorder. You wouldn't do that. So that's one feature of a HIPAA compliant Zoom. The other key thing that I mentioned to my colleagues is having a waiting room function. So say you're having a 9 o'clock visit and a 9:20 and a 9:40, you don't want the 9:20, 9:40 patients to kind of stack up and kind of barge into that room. So you can either have a waiting room function, or you can have totally different Zoom IDs for each individual patient. But those are probably the two things that I think from a privacy perspective are really important. And people have heard in the lay press about Zoom bombing and things like that, about people somehow getting the addresses, and so you always want to keep those private as well. Is there a chat?
Thank you.
In there?
Yeah, I did see a question come in. Kay King, are you able to unmute? Okay, maybe not. So the question is,
yeah,
go ahead.
do you use the telemedicine equipment with ECG, small camera probe, and stethoscope in one? So that's like, there are certain vendors that offer that, like I think TytoCare is one of the vendors. Care Innovations is another. We have not, primarily because, quite honestly, there hasn't been a huge need, and it's not clear like who pays for that. Is this DME? I think if you had like a more of a kiosk model, that might make sense. You could have kind of more of a remote outpost. But otherwise, they're kind of expensive. They're anywhere between $250 to $500. So we haven't done that. But there's certainly those available, from getting a pulse oximetry that you can mail to a patient, or e-stethoscopes that are around $250. But it's often at a price point that's hard for patients to pick up, and it's not yet considered to be a durable medical equivalent. So I don't know if Dr. King wanted to type a little bit more. She says that they're using in her clinic. And I think it makes sense, especially if you're using it just for the whole clinic and you're trying to maybe record a heart sound or lung sounds for the the specialist at another site, that's really helpful and kind of improves the whole experience for the patient.
And where is her clinic?
I don't know. I'm just reading her
Do you
chat.
remember?
That's
Oh,
Kate.
sorry. Oh, yeah. Okay. Oh, sorry.
Probably know better
Okay.
than I do. Yeah.
No, yeah. Great. Not durable medical equipment. Got it. And I know that there's been quite a bit of conversation about the sort of more telemedicine EKG because, we are increasingly using medication and TB that, does have, that does need more monitoring. So it's interesting to talk more about that.
Yeah, so I think this kind of falls into the category of telehealth that we call asynchronous, or sometimes it's called remote patient monitoring. And the idea here is that you're getting some kind of a physiologic measurement on a patient. It could be blood pressure, heart rate, weight from a scale, a pulse oximetry, like I said, or even, my watch, which is an iWatch 4, and it's FDA approved for picking up AFib. So you should know that Medicare does pay for remote patient monitoring, pays for both the setup and monthly monitoring. It's not a whole lot, it's anywhere between $20 and $50, but there are codes for that. The one thing I would say is just make sure that whatever you're using to monitor patients, that you try to use the same technology and that it has been FDA cleared itself, okay? So I mentioned that the iWatch is FDA cleared, but only for atrial fibrillation, not any other kind of rhythm disturbance. So just make sure it's good data, that you can trust that data, and that you have a system for monitoring it. You don't want to have this arrhythmia kind of come in at 3 o'clock in the night, and there's no one who's kind of picking that up. So just make sure you do have a process for any kind of urgent result that a patient might be submitting, so that you can act on it. And along with that is like, how do you get it into your electronic medical record, and that it gets acted upon.
Great. Lots for us to think about. Any questions that have come up? No? Okay. Great. Well, I think I have exhausted my questions.
I think we have another one in the chat, Lana.
Oh, yes. Thank you.
Yes.
Thanks for that.
You want me to read it off?
Yeah, go ahead.
Okay, so it says, can you talk about how or if you are using telehealth to screen COVID suspects?
Yeah, sure.
Great, thank you.
So the first thing we did is we created a chatbot within Amazon, because we just got our contact center, all our access points at UW-Madison just got overwhelmed with people with questions about COVID-19. And we had to be able to triage those people into patients who, need to come right to the hospital right away. They're very sick, to patients who probably need testing. And then we knew the vast majority of patients did not, at the time, with the original screening criteria, probably didn't need to be tested, and they could just recover at home. So we created that bot, and it kind of, the middle category that I was talking about, steered them to virtual care, either with their own primary care doctor or through the virtual clinic that I talked about. And so that was a great way to just handle the huge volume. But we're trying to use telehealth as a triage function. So sometimes just being able to eyeball them, if they look super tachypnic or their lips are turning purple, that's the kind of time that we'd say, okay, let's verify your address and we're calling 911. We need to get someone to you right away. And then the other strategies are, using our tele-ICU product, and even just simple tablets for not as sick patients to communicate with their care team and with their loved ones, because we stopped allowing so many visitors, and a lot of our patients are pretty lonely. They don't have the ability to take visitors the way they used to. even if they don't have COVID-19. So we've deployed a tablet solution for patients on the regular wards, and then that tele-ICU with a really nice high-def camera for the ICU patients. And so I think there's been a variety of approaches from triage to taking care of your established patients. And we're really kind of leaving it up to clinics and providers as to what's appropriate for each patient. You know, some people still need to come in, not that many, but sometimes we still need to really lay eyes on them. Some people are comfortable with telemedicine, some we're just doing phone. So it's kind of a mixed modality we're doing. And I work at Harborview, and we are indeed working in, you know, resource limited settings where not everyone has access to broadband, or they don't have a smartphone or a tablet. And this is where a lot of the telecom providers have stepped up, and they are offering either free or really reduced access to broadband. We've had a couple of the telecoms donate, you know, used phones, and also some have donated some of these tablets as well. So you gotta be a little careful about donating those to patients. You might be able to own arrangements where it's leased, or, you know, it's given with the understanding they're going to give it back. So just that's the only thing I'd say about you can't actually give things that have a monetary value to patients.